It's a pleasure and an honor to be here at this meeting and share some of the work that we've been doing in expanding reach of primary care services. Can the lights be reduced so that to the urban disadvantaged? So I'll just take you through this quickly. As respected chair mentioned, that India is growing rapidly, and one of the fastest growing segments is the urban poor population or the slums. And you have information from Mumbai and Delhi where we know that there is sharp disparity in what reaches the people living in the type of area that we are right now having this meeting in, as compared to people living in, say, northeast Delhi, which is also Delhi for all practical purposes, but it's a very different type of Delhi if you happen to visit there. And the irony is that all the cities are prosperous because they have cheap labor from the urban poor. So we are able to get delivery at home at almost no cost because you have people who work at 250 to 300 rupees a day. And many of us probably know that in many Western countries that's not just possible. I mean, you can't have anybody working at such desperately low rates. So I'll take you through quickly through a few disparities that we see. Chronic undernutrition is an indication of health which encompasses several dimensions. And I remember that in the concept note, it was mentioned that we should try and see how different sectors interact when we talk about healthcare. And we can see that in the urban population of India, about 54% children less than 5 years are chronically undernourished or stunted. And this figure, even though it is old, it would not have changed very much because stunting does not improve very fast. Stunting means that it's been a deprivation for a long time and from various factors. The child survival and the infant survival also is very bad among the urban poor. We often have the urban versus rural comparison where it appears that urban are far better, but we should also be aware that within urban there is this hidden segment of the population which is also often overlooked, where the child survival rates are quite bad. Then inequitable access to maternity services. I just picked one indicator, which is postnatal checkup, and just one postnatal checkup within 42 days of delivery is also very low. If I had taken the ideal indicator, which was 3 postnatal checkups, we wouldn't have been able to see this bar. It was almost negligible. And we also notice and observe in our work, I work very closely with all sectors, including the community, that the capacity of women and education of women, their ability to take decisions, their feeling of being empowered makes a very big difference to how they are able to take advantage of a healthcare system. Another challenge in urban areas is that a very large proportion of the slums are not part of the official lists. So this table shows the results of studies that Urban Health Resource Center conducted in Agra, Dehradun, Bali, Jamshed. Bali is a city just outside Kolkata. It's a small city in Havara district, not very small now, it's about 500,000, so I don't know whether we should call it small, but because India has a very large number of very big cities, still considered to be small. Jamshedpur, Meerut. So we found that there was a very sizable proportion of unlisted slums, But sometimes people can dismiss the study of a civil society organization because it is not as authentic as government studies. So if you read the last line, you will notice that the Ministry of Statistics found that nearly 50% of slums in the country were not notified. So, the government also found same figures when they did the study. And the non-notified slums are far worse than notified slums, again from the Ministry of Statistics study. And these are the multiple dimensions of issues which affect health in slums and disadvantaged urban localities, housing, various types of services, the location of the slum. Sometimes the slums can be very close to a large drain. Accessibility of public health services. The health services are often located in areas which are more advantaged. Because for a doctor also it's not easy to go inside Northeast Delhi, for example, inside Mustafabad, Tukmirpur. These are areas in Northeast Delhi, which is a huge population, very densely populated. So often the situation is that the services are quite far. And alcohol and gambling also affect health-seeking behavior and health care. And the negotiating capacity of the community. If the community is organized by some civil society group, then they are able to get health care at their community through outreach camps or even get dispensaries sanctioned. This is the same type of thing with the lens of the social determinants of health. I'm sure many of you have heard about this famous global concept of considering social determinants of health, where economics, environment, and other dimensions of development are considered. And here is the interplay of different sectors and actors, which I remember Dhirendra mentioning that we should try and cover in this session. So if we start from the right, it's the health department, because we are talking about health care. We also have the labor department, because the Rashtriya Swasth Bima Yojana is of the labor department, and the labor department also has other schemes for casual workers or any other type of workers in urban areas as well as in rural areas. Then the Department of Women and Child Development, it has several programs for health and nutrition. Urban planners plan the city. So we see some interesting planning, like in Delhi we see the New Delhi area where we are presently discussing, and we see many other parts of Delhi which are very different from New Delhi area, and if you happen to visit them and spend a few days there, you will feel that this is not like Delhi. So there is nothing which is similar to the New Delhi area. Or if you look at the other way around, if that is Delhi, then this is probably not Delhi. And then we have NGOs or other civil society groups working for slum well-being. We have women's groups or slum groups in the slums. We have the ward level politicians. There are all types of politicians, but there are some well-intentioned politicians also. Primarily, of course, because the population is their political constituency also. And then we have municipal corporations which provide many services which affect health directly. These are the differential housing conditions. I just want you to look at the variance in the housing, and the last picture shows a number plate. So you can see that the first picture on the left is just huts. Then you have this next to the railway line. Then you have a slightly better hut, and then you have a number plate. So within slums there is differential housing situation, and this is something which is important to understand, that we can't consider that all the slums are identical. These are some more scenes from different slums. The one where you see these children standing on a drain is from Jakarta. And you can imagine this woman washing utensils on the railway track. This is the same railway track you saw in the previous slide where we had houses next to the railway track. This was in Kolkata, and there's a child maybe 2 feet from her. So we have children playing on railway tracks and jumping back to their house when the train comes. Of course, there are many accidents that take place. So I share 8 solutions which can be used to address this challenge of primary health, and some of these solutions can be done using technology, some can be done without technology. Why I'm emphasizing on solutions with and without technology is that because India is a very big country, and all across the country, if we expect everybody to become comfortable with use of technological platforms, that will be something which we would be misleading ourselves. We have many officers, many administrators across our country who will not become comfortable with technology probably for the next 50 years. Because it just takes a while, just like my previous speaker said, that it takes a while for things to build up. And likewise, technology also takes time to get absorbed. So this is a spatial mapping of cities. If I were to use only the technology word, I would have said GIS mapping. But I have consciously used the word spatial mapping because this can be done also by a non-technical person, the old-fashioned draftsman who used to make maps and still make in many places across the world. So this is a map of Agra which shows the listed slums. The red dots are the unlisted slums, and this is the complete picture. And if we overlay the health facilities, we can have the distance of health facilities from different slum clusters. This is a similar map of Meerut, which is about 80 kilometers from Delhi. It used to be about an hour and a half journey. It's increased to about 2 hours and now about 3 hours. So it's very close to Delhi, but still because of the traffic, it takes a long time. These are the unlisted slums, and this is the complete picture of. So this is one approach which is innovative, which can be used through technology platforms as well as non-technology platforms and improve access to primary health care. And as you are probably aware, this has been included as a mandated strategy in the National Urban Health Mission of the Ministry of Health and Family Welfare. This is an example of a ward in Mumbai. This ward is more an administrative ward, not an electoral ward. It is the R South ward, or also called Kandivali. This is a neighborhood map. This is drawn in slums, basically to track people who are left out from any type of health coverage. A similar map, a closer view where you can see how the people mark different areas in different colors so that they can take responsibility for the households. This I'll skip. This is a busy slide. It has a lot of details. Now the approach of the civil society making the demand side stronger is very crucial. So this is the women's groups in the slums. And as some of you who may be aware with the Government of India policy initiatives on primary health care for urban slums, there is the National Urban Health Mission, which has again mandated this as Mahila Arogya Samitis. So this has been mandated in the National Urban Health Mission. We have groups at the slum level and then a representative from the groups at the larger cluster, which we call the Federation or the Congress of the community groups. This is the same diagram also showing the UHRC small offices in Indore and Agra. 2 to 3 persons are the social facilitators who build their capacity and help them access the healthcare services from government, private, charitable, whatever facilities are available. Now this is the type of risk insurance, if you want to use that word, or collective revolving fund, which has been, we've tried it in Agra and Indore and it works quite well. And this again has been mandated in the National Urban Health Mission. in the National Urban Health Mission, they have used this language, revolving community fund, to be managed by slum-based community groups and loans given from that fund for health and other needs. For example, if the family requires some money for maternity care or any other type of health care, they can borrow and repay on a moderate interest so that they can have easier access to money and don't fall in the trap of money lenders. This is the usage of this fund from a small cluster, so I'll skip this, the details, but you can see that a very large proportion of the funds have been used for health needs, and they've also been used for education and other social needs of families. The fourth approach, which is helpful, it is partially technology based and partially non-technology based. So what you see is a petition from the groups or the community from the slums to the civic authorities, and you see the response. Of course, it doesn't happen instantly. It takes sometimes a year, sometimes 2 years, sometimes 3 years. We need to just remain perseverant. It takes quite long. The technology angle is that many civic authorities have now introduced a calling number. So you can register your complaint through your cell phone to that number, and it will get registered in their system. This is a letter from the local politician in support of the community petitions. So this is also something which is worth considering, because politicians have an important role to play in our country, and in the past year or so we have seen quite a lot of political activity, which interestingly is continuing even today, despite the fact that we already have a government which is 6 months old. But we still have a very strong political activity which is going on in the forms of rallies and speeches. But sometimes the politicians can do real work like this, that they wrote a letter in the support of the community petition for an Anganwadi center in the slum. And this is not technology, but this is real life. So sometimes the women have to wield bamboo sticks to actually remove the alcohol vending stations and the gambling joints. So there are times when the police officers don't really bother much, and then we see this situation, and because we've been able to encourage them to engage with the media, so they are able to get the media involved as well. These are cleaner drains. The left picture is clogged drains, on the right is cleaner drains, with the help of the requests from community groups to the Nagar Nigam. These are electric connections. I'm sure you are all aware that a very large number of households have these hooked electric connections, which you see on the right, and then slowly some of them are getting the proper metered connections. These are the slum pathways. You see the unpaved pathway, and then you see a freshly paved, and then you see one which needs repair. This is water supply in the slums, and we were able to get the Agra Nagar Nigam to agree to this idea of installing large water tanks so that the submersible pump doesn't get broken very quickly. This is the other type of water supply. This is self-help, which is real self-help only. There is a drain which people had to cross to reach the other side of the community, and you see people going through the drain. So they built a bridge on this drain themselves, a temporary bridge which is washed away by the rain and again rebuilt. The rainwater enters. We have seen climate change as something which is very a contemporary issue of debate. The rainwater enters houses, so the families are slowly increasing the plinth of the houses. Lack of picture ID is another big challenge in slums, because they are often also considered illegal. So this is another effort which many organizations have been doing, and we have also been doing, so that people are more legitimate citizens and they can access different services quite well. I mean, I was reading an article where I learned that even in the dispensary, sometimes the doctors ask for an ID proof for giving health services, which is actually an illegal activity. But I think probably just to reduce the burden of the patients, that is what they must be doing. I have not seen it myself. I read it in an article in one of the journals. So these are the multidimensional efforts which the demand side does with all the departments which we saw earlier, and that is how they are able to improve their linkage with these different sectors and also improve service access to their communities. The seventh approach is a public-private partnership approach. This is from Guwahati and Tamil Nadu. There's a large private hospital which has a charitable orientation, so they have been partnered with the government, and they provide outreach services, primary health services in their OPD as well as hospital services. In Uttarakhand, there are 21 urban health centers that are run in partnership with private organizations. And this again is part of the National Urban Health Mission approach. This is the last approach that I will share, where we are using whatever is available, which includes telecommunication, like the small cell phone that you see, the auto rickshaw, the trained doctor, the health center, so that the patient can be transferred earliest to the health facility. Several policy documents have been issued, so we have made progress on the paper front. So, and it is, India has a good history of making paper progress. We don't have bad policies usually. We've been having very good policies even 20 years from now. And so we've made good progress. But are we missing something? This, I think, is what we are missing. There's a need to translate words into real action. One example which I'll give you is the urban health guidelines were issued in 2004. And we are today in 2014. And the National Urban Health Mission has been announced by health ministers, health secretaries, state chief ministers, prime ministers, several times. I don't know how long they'll be continuing to announce it, but they've been announcing it year after year. There has been budget allocation for the National Urban Health Mission on several occasions, which has not been spent. So I think this is the need of the hour. There is less need for discussing the strategies and more need for action and learning from the action. And when we talk about action, I'm reminded of this quote which many of our children have studied in their school books, that if we remember the face of the most disadvantaged and the voiceless person and we try and reach them, there's a likelihood that all others will be reached automatically, because that is the most difficult person to reach. The same holds true for all the schemes which the previous government and the present government are running, including the Aadhaar scheme and now the Samagra ID. If some of you must have heard, they have come up with an integrated family ID scheme, and also the Jan Dhan Yojana. So if it reaches the most voiceless person, then there's a likelihood that it will reach others and will actually work. But I always end with hope that all people from all sectors with their strong willpower will help a more accountable health care system in our country. And a small body of determined spirits fired by an unquenchable faith in their mission can alter the course of history. This was said many, many years ago, and it appears to be relevant even today. Any guesses on who said this? तो बहुत साल पहले कहा गया था, हिस्ट्री के बारे में कहा गया था. आज शायद हम लोग हिस्ट्री की बात अक्सर नहीं करते हैं, बट हो सकता है 100 साल बाद लोग हिस्ट्री की बात आज के कॉन्टेक्स्ट में कर रहे होंगे, और ये डेटा तो दिखेगा लोगों को ना कि कोई चीज 2004 में अनाउंस हुई, फिर अनाउंस हुई, फिर अनाउंस हुई, बजट एलोकेट हुआ करोड़ों रुपए का। एक घोटाले होते हैं कुछ कुछ हजार करोड़ के, ये तो बहुत छोटा सा है। इसमें घोटाले के बाद भी काम हो सकता है। मतलब मान लेते हैं 50% लोग घोटाला कर देंगे, तो 50% से तो काम कर लें कम से कम, पर वो काम ही नहीं हो पाया अभी तक। थैंक यू सो मच।